A warm Caribbean good afternoon to everyone. You can unmute and let us know you're out there, or you can give us some kind of indication that you are hearing. Beautiful. So I'm going to do that again. A warm Caribbean good afternoon to everyone. And as a team on American Airlines would say, we're glad you're here.
Good
We're
afternoon.
aware that you had options, but you chose to be here. At this time, we want to welcome you to the CARAIFA Foundation, CARAIFA Connect, Day of Common Concern panel discussion. As we continue our time to connect together, to do the invocation, I'm going to ask you to help me to welcome someone who will always hold the CARAIFA Foundation dear to her heart, our Vice President, Diane Cummings.
Thank you, Madam PRMC Shirley. And of course, I do hold the CARAIFA Foundation dear to my heart. Isaiah 41:10 tells us, "So do not fear, for I am with you. Do not be dismayed, for I am your God. I will strengthen you and help you. I will uphold you with my righteous hand." Let us bow our heads and our hearts in prayer. Heavenly Father, we come before you today with grateful hearts as we gather for the Caribbean Association of Financial and Advisors Day of Common Concern panel discussion. We thank you for the privilege of uniting us as professionals, leaders, and advocates across our region with a shared purpose to uplift, support, empower the people we serve. Father God, we lift up to you all those in our Caribbean family who are suffering from critical illnesses. We pray especially for those battling with cancer and kidney disease, and for everyone facing emotional, physical, or financial challenges because of illnesses. May your healing hands rest upon each and every one of them. God, grant them strength, comfort, peace, and renewed hope at this time. We bring before you the people of Jamaica, dear God, the island of Jamaica, and all those who have been affected in recent times. Surround them, Lord, with your protection and your grace. Bless the families, the communities, and the caregivers working tirelessly to rebuild, to recover, and to restore. We offer a special prayer, oh God, for those in Jamaica and across the region who are coping with critical illnesses, Lord. May they feel your presence, Lord. May they receive the support they need in this season of challenge. As we begin this panel discussion, Lord, we ask that your wisdom guide every conversation, Lord. We ask that you inspire each and every one of the panelists right now, God. Ignite meaningful dialogue and enlighten our minds so that the discussions today will be impactful, so that it will be purposeful and effective. May the insights shared lead to better care, stronger advocacy, and greater unity in fulfilling the mission of the CARAIFA Foundation. Bless this gathering, oh God. Bless us, Lord, and let everything we do bring honor, glory, and hope to those we serve and to your holy and precious name, dear God. Amen.
Amen. And so say all of us. Thank you so much. As a Jamaican, I really felt that. And on behalf of the people, we really appreciate the prayers and thank God for all that will be done today. And I know the stage is well set. Growing up I would hear my mother talk about the big C. Cancer was such a taboo word that no one wanted to call it. The big C brought with it pain and fear. Persons were fearful of death and anxiety, and this was of no mean order. Families would be separated from their loved ones as life was taken away from them. This disease was like a monster with which no one wanted to be associated. In fact, breast cancer, the cause and breast cancer caused the death of 670,000 persons globally in 2022. But thank God, in recent times, and now, people's attitude to the big C has evolved. And there's a fight against it, particularly in the breast, and a support for victims. This fight and support have taken up the international space, with October being designated or recognized as Breast Cancer Awareness Month. Another thing I grew up hearing, especially as a Generation Z, a Gen Z, was that diabetes was a debilitating disease. As described, this critical illness has the ability to weaken the organs in the body over time. And we see that November is being recognized as Diabetes Awareness Month. For October, we wore pink. I'm still in the pink mode. And for November, we are to be wearing blue as we recognize diabetes awareness. I think I did my nails for that. This afternoon, we will be deliberating some issues to discuss and spending some time to discuss these two topics that have been with us in the past, still with us, and will be with us in the future. But the key thing is how we manage. How will we manage these diseases? Before we dive deep, we want to ask the leader of the pack from CARAIFA to welcome you like only he can, and to introduce the CARAIFA Executive Committee. With his pleasant demeanor and the smile in his eyes, let us invite our president, Gerald Cruikshank, to the virtual lectern to welcome us. President.
Thank you very much, Director Shirley. Appreciate it. And to everyone here this afternoon, I want to say thank you. First, allow me to introduce my fellow executive members as directed by my Director Shirley. We have my Vice President, Mrs. Dion Cummings, our immediate past President, Mr. Hugh Meredith, our Education Chair and Interim Secretary General, Mrs. Alicia Birch, our Regional Congress Coordinator, Mr. Denton Atkins, and of course, you know this lovely lady who was speaking to us, who is moderating this program, our Director of Public Relations, Marketing and Communications, Ms. Shirley E. Daly, and none other than our CARAIFA Foundation Chairman, Mr. Larry Taichu. On behalf of our executive and the board of CARAIFA, I bring greetings to all of our online Zoom attendees here this afternoon, throughout the entire region, to the CARAIFA Foundation's Day of Common Concern. This event is being held under our CARAIFA Connect as a way to reach out to our members, their families, their friends, as well as their clients, to live a healthier lifestyle. I would also like to take this opportunity at this time to extend our sincere thank you to our esteemed panelists of doctors today, Dr. Diane Brathwaite, Dr. Marisa Nimrod, good colleague of mine, Dr. Rajendra Rampaul. These doctors have to be given kudos for taking time from their very busy schedule to be here with us this afternoon to not only share in ways that to live a healthier lifestyle, but also to take questions from each and every one of you, as well as to give as a positive answer into how we can treat these illnesses. The director mentioned that this month is in terms of diabetes, and last month we were in terms of cancer, breast cancer. But we know there were many other illnesses we are plagued with throughout the region. These conditions, and as we know, affect not only us personally, but also affect our families, our friends, our colleagues in our work life, as well as our clientele. So please feel free to share not only the barcode for this meeting, but to share the information you will gain from these professional doctors that we have here this afternoon. Good. And I want to say, enjoy the rest of the program. It is a very unique program that we try to reach out to everyone throughout the CARAIFA family, throughout the region. And thank you very much. Director Shelley?
Thank you, Mr. President. Yes, we feel the warmth of that welcome, and we are really anticipating all that you have said will be happening later. The next speaker has been anticipating this day, and he's all excited. To share about the CARAIFA Foundation is the gentleman, I call him the gentleman who has that guttural voice, radio voice. Let's welcome the chair himself, our foundation chair, Mr. Larry Taitu.
Good afternoon, everyone. Everyone throughout the Caribbean diaspora. And good afternoon to Madam Chair and to our panelists that are on right now. It gives me great pleasure to say a few words on the CARAIFA Foundation. The CARAIFA Foundation was founded many years ago, primarily to bring awareness to these what we call dreaded diseases that plague not only our region, but throughout the world. Cancer being just one of them, things like renal failure, hypertension, diabetes. I myself have lost a big sister through pancreatic cancer 26 years ago at the ripe old age of 42. And so as we do what we can as a foundation, as part of CARAIFA, the Caribbean Association of Insurance and Financial Advisors, awareness, and the doctors will speak to it, is just the first part of it. Availability of what is available throughout the region is another part of it. The third part that we try our best to do is raise funds throughout the region, from the companies, from our advisors, from well-wishers, that we can do whatever little bit we can or whatever much we can in the give back to our societies and the underprivileged, less privileged, who is unable to fund a lot of this stuff themselves. And I know that one of our doctors today is going to speak to that because she's going to talk about what is available as well. But we all know that there are so many things that are available, but they're available at a cost. But we'll get into that as we go into the panel discussions. So I want you all to feel free to post up your questions as they come along on the chat, so that when we get into the question and answers later, what you may not have gotten the answer to during the presentations, we will see how best the panel can best address your questions. So, Madam Chair, without further ado, I would like to pass it back to you.
Thank you, Foundation Chair Kaitu. Our Foundation Chair shared with us some housekeeping rules and a little bit of how we'll be proceeding from here. And feel free to use those buttons at the appropriate time, the icons. Therefore, what we will be doing is that we'll be asking our first presenter to make her presentation for about 15 minutes. And after that, we'll have a little something for you. And then we'll have our other presenter making her initial presentation for about 15 minutes. During these presentations, please make a note of your questions because we'll be entering the question and answer segment after the presentation from each panelist. Then we will be getting into the lively discussion, have your participation, and when you are recognized, once you indicate that you have a question, or if we were not able to pick it up in the chat, we'll ask you to use the button to raise your hand and we'll recognize you. We're also going to ask that if you're writing your questions in the chat, that you state your name and the country from which you are. And if you're also going to ask your questions orally, it's the same thing. We want to connect with you and we want to ensure that the Caribbean togetherness is strong. So please, once you're saying your name, indicating that you want to ask a question and you're acknowledged, say your name and then ask the question. All right. We want to be moving right along. And as you know, we have the experts, members of our panel who will deliberate with us on the topics of interest. And incidentally, today is World International Diabetes Day. So we're right on the button and quite current in what we're doing. Our first panelist is a distinguished physician, public health leader, and the Chief Executive Officer of MD Medical Consultancy Limited. She oversees executive medical assessments, health education, and occupational health services for both public and private sectors. As chairwoman and CEO of the Caribbean Association of Oncology and Hematology, known as CAOH, she has been instrumental in driving initiatives like the development and implementation of harmonized cancer treatment guidelines tailored for resource-limited Caribbean settings. Under her leadership, CAO has hosted regional conferences focusing on a holistic approach to cancer care and elevating standards in oncology and hematology. A passionate advocate for early detection, standardized treatment, and professional education, she continues to strengthen the Caribbean's capacity to deliver quality care. I say, to exhort on breast cancer, let us welcome the thought and transformational leader to the virtual lecture, Dr. Marisa Nimrod.
Thank you very much. Good afternoon, Madam Chair, directors, members of the esteemed panel. It's quite an honor to be here to actually speak about my passion. I am a public health consultant / physician who's pretty much passionate about listening to the patient side of the story and trying to come up with a creative, solution-oriented approach so we can translate that into policies and guidelines. And to date, as of this year, we're officially the technical advisors to the OECS. So we've actually gotten the unanimous approval to start putting together a work plan, and we also had a mandate at CARICOM this year where we are actually working with the CMOs across member countries. So we're quite excited, to see the footprints that are made. My clinical chair, Dr. Dwight Lowe, is from Jamaica, as well as Professor Gillian Worf, who started this entire venture after Dr. Bovell founded it. So I'm going to get into a presentation called Breast Cancer 101, what you should talk about, because sometimes these discussions do come up. Oh, wait, hold on. Okay, great. So if everyone can see my slide, right? Breast Cancer 101, what should you talk about? Okay, so first we talk about the definition of breast cancer. So it's always a pink topic. It's always been an interesting topic for persons who are experiencing it, who are lending support as caregivers. It becomes, when you talk about cancer, it becomes a community approach, whether it's a best friend, a relative, physicians, everyone gets involved. And normally we would view it as, we call it an MDT approach to care. So let's have that discussion. Can everyone see my slides by chance? Can you see my slides?
Yes, we are seeing it clearly.
Okay, thank you. Okay, great. So I like the analogy of a traffic light. So breast cancer is actually the uncontrolled growth of cells in the breast tissue. So it doesn't stop when it's injured. So normally God created it. When something gets injured, you have two mechanisms. You can actually have repair and healing, or you can actually have, programmed cell death, which we refer to as apoptosis, where it should be destroyed. However, in breast cancer, if there's any injury that happens at the cellular level, whether it's especially from a mutation, this cell continues to grow, and that's where it all begins. So the epidemiology that we're using still hasn't changed to date, right? So cancer overall is still the second leading cause of death globally, right? It was 9.7 million deaths in 2022, if we're referencing GlobalCan, right? So normally the cancer registry is sometimes about 2 years behind, because we source our data from the Caribbean and then it's sent up to the US, and then it's actually plugged in. So circa about 2024, it's gone up to about 9.8, just a little bit more, because COVID would have obviously put a little stopgap with respect to the screening and the treatment aspect of it. But overall, it's still the second leading cause of death. There were about 20 million new cases in 2022, which has gone up slightly. And the ratio of men and women it was 1 to 12, but now it's like 1 in 8. And in men, it's still about 1 in 9, because men do get breast cancer as well. When we look at our statistics in terms of the epidemiology, we still have high numbers of cervical cancer, breast, prostate, and colon cancer. That still supersedes that of the USA, right? At least 2 to 9 times higher. So let's focus on the anatomy of the breast. So persons say, I have breast cancer, it's told to them, and we want to know exactly where, because there are different types of breast cancer. We have ductal, we have lobular, we have pathway. So let's have a look and see. So the items that are labeled right on top of the bones, that's to the back of the chest wall, right? So that's my rib cage. We have 13 and 12, which speaks to the pectoralis muscles. We have minor below, major on top. So when men go to the gym and they're flexing, so that's really what we're trying to strengthen and add some tone to that. And even in women, and on top of that now, we have that mass, that yellow area is actually fatty tissue. That adds to the volume. We're looking at 10, so we have a retro mammary fat, right? So that's behind the fat, just on top of the pectoralis. And then as we're looking out here and we go out a little further, right? So I can do this, right? So we're looking at purple areas, and in purple areas, that's referred to as a breast lobule. So remember, the function of the breast really is secretory, right? Apart from aesthetically pleasing, its function is to make milk, right, going forward. So we have the lobules here at number 2. So this is a potential area that can develop into cancer, and it's referred to as lobular cancer or carcinoma when it becomes cancerous. And then we have the milk that flows through, right, the extralobular duct. It starts moving into the main duct, and then it passes right about here, the ampulla, that's like a holding well, and then it goes out towards the nipple, okay? The other area that can develop, and is one of the more common ones, is actually going to be ductal, right? So you normally hear persons say, my pathology report says that, you know, it's ductal or invasive ductal. So those are the 2 types in particular, right? At 4 and at 2, however, we can have inflammatory breast cancer, which presents here with respect to the skin, which is the largest organ, that's at number 7, right? And sometimes even the nipple can be affected, and it can start getting dry and scaly, which we can refer to as Paget's, right? So just giving you an idea of what it looks like. So when we speak about actually doing a mastectomy, which my colleague will speak about, you have an idea of where it's at. So let's look at the percentages. When women come in, you know, where do you find it in particular? Most times when they present, you know, they come in through the primary care services. So it might be a nurse practitioner, or it may be a physician, depending on who they encounter before they get to my specialist teams. You will hear them saying, you know, I was taking a shower and I felt my hand brush against something and it felt hard, and, you know, I suspect it's a lump. Sometimes their partners might actually feel it, depending, you know, so sometimes that's how they would present us when they come through primary care. So if we look, we can see most of it, we divide the breast into what we call quadrants, and we can see up here on the outside, that's the upper outer quadrant for the breast, right? That's 25% presenting here. Then we have on the inner side, the upper inner quadrant, 8%. We have lower outer, lower inner. As we can see, we still have here this nipple areolar complex, as we refer to it. Presentation, sometimes you might have it right behind here. We'll pick that up on screening. 1% may present up in the axilla. So we say, you know, local terms, sometimes we might feel like a gland that's up under the armpit. So that's really axillary lumps or nodes that can be felt under there. And that's because the body is trying to mount an immunoprotective response. So those are some of the areas that would be affected, right? And then we have 52% that can be overlapping or unspecified. If it's a red area on the breast, it may be a sign of inflammatory, etc. So again, this gives us an idea in terms of the locations. Right, so who does it actually affect in terms of the epidemiology? So we established it's the most common cancer in women, and it's actually second to lung cancer in the number of cancer-related deaths among women. However, as noted, once men have that tissue, that increased area on the chest wall, which referred to as gynecomastia or male breast, men can also develop breast cancer as well, and the treatment is the same. So put you at risk. So family history is very important. It used to be a taboo, as we noted before, to have those discussions. Who had cancer, who did not? And normally it will come out when somebody, you know, seems to be familiar with the history, and then there's an aha moment for you to know if it was a first-degree relative, etc., who may have presented. And it doesn't have to be cancer alone, just finding out about any history of other types of cancer, because sometimes we have what you call clusters or hereditary groups or genetic levels that would also key you in. But in women in particular, we're looking at long-term exposure to high levels of estrogen. So estrogen is that female hormone that actually, you know, develops with the menstrual cycle. So the onset of menses is what you refer to as menarche. So some persons may develop and have periods that start before 12, before 11, sometimes starting as young as 9 years of age. Or if you have a late onset of menopause, menopause is normally circa 2 years before, 2 years after 50. But if they keep going after the age of 52, then we know that we still have these increased levels of estrogen that's circulating. We say nulliparous, persons who've had no children or who choose to have children at a later age for whatever reason, if it's going to be career, etc. We also classify that as a risk factor. Obesity, right? Hormone replacement therapy, because there have been some new changes with respect to the approvals recently by the FDA with respect to hormone replacement therapy. But the traditional ones previously did give a challenge for some women. So that's why it was included here. Alcohol use, and we're talking excessive levels, smoking for all cancers, inactivity, because most of the times we're very sedentary. We're not getting up to move and to exercise. And then our diet, literally, food is medicine. If you're not having and consuming a well-balanced diet, you're going to have the lack of those healthy minerals, vitamins, antioxidants. And as a result, that can also increase your risk of developing breast cancer. So how do you want to check? You want to prevent it. So we say screening. So screening with respect to epidemiology, public health, or in medicine means going to check to see if something might be there, even though it isn't. So you're not going when you have a breast lump, you're not going with a nipple discharge, you're not going when any of those things are happening. You're going from the reproductive age, from as young as sometimes 24, we start screening when women are preparing for families, etc., because the ages of presentation are becoming much lower, right? So I think my youngest patient was stage 4 breast cancer at the age of 16, and we're having younger and younger women, and especially in the US where I trained for a while, presenting with breast cancer at the age of 40 and even below. So what do? We actually try to set an appointment at least once a year, have that discussion with a physician, right? Which also includes a cervical exam or pap smear, and we have that done in terms of women health or preventative assays. We start with mammography, which is like a low-dose X-ray. Normally by 40, we start at 40 for screening now. And then we physicians would do clinical breast exams and then speak about breast awareness and self-examinations in terms of what to feel for, what to look for. Okay, so I'm not sure if I've closed my 10 to 15 minutes, but overall, in terms of when you should have the assessment,
Did Doc fall off?
She did,
Oh,
but
she's
she
coming
just
back.
logging back in, yeah. Probably pressed the wrong button.
okay, my apologies. I had to switch with respect to my electronic devices. But what I was saying for the time being, in terms of what to look for, persons, especially women who are, we say not or non-menopausal, premenopausal, they're not in menopause, you try to find a particular time of the month, not when ovulation is going on, right? So not the day or 2 days before day 14, when you know that you're probably going to get to the peak of your ovulation cycle, because if you do, what happens is that you actually feel lumps, which might be fibroadenomas. They're non-tender, but during that time of ovulation, it actually feels tender. So as we advise our younger patients, try to do it like right after the periods have passed, like in that week after. So it's the same time every month. Women who are menopausal, you can choose any day. It's not going to be affected because we have no periods, we have no hormonal changes going on. What do you feel for? You try to feel, if there's a lump, you try to move it around. If it's fixed and it can't move, does it feel craggy or hard or irregular? Some of those things are important, and you make a note of it, and you shouldn't be afraid to have that discussion. It's important because mental health is so important to my patients. When you go through a diagnosis of probably suspected cancer, a million things go through your mind, and the last thing that you need is anyone stressing you out. So as I tell patients, when you get to that discussion with your practitioner, ensure that they understand they're speaking the same language. If there's a bit of hesitation, make sure that it's clear before you do anything, because medicine is supposed to be a team effort, right? It's a relationship that you build with the patient. You gain their trust and you let them know that whatever that you're choosing to do, because we write the guidelines for breast cancer and for at least 6 others, whatever you choose to do must follow best practice in terms of standard of care. And sometimes if you feel uncomfortable, you can have a second opinion. Nothing's wrong with getting a second opinion to find out if the solutions are pretty much the same. I think this is all about wellness. At the end of the day, health and prevention comes first. And we just want patients to have the best possible outcomes so that the quality of life, your mental health, your support system and networks, the most, how do you put it, grounded support systems that you can have as you actually, address whether it's a personal challenge or journey or you're supporting someone else. I just want to put it out there that forums like these create positive environments that patients can feel safe to have those discussions. So thank you for allowing me to contribute.
Wonderful. Thank you so much, Dr. Nimrod. And as I listen to you, I realize that the breast is not only best, but it is quite complex. And I know I have a question for you when it's time.
Yes, ma'am.
Yes. Thank you so much again. And we're looking forward to dive a little deeper into our discussion. Ladies and gentlemen, I believe you would have been expecting us to have another presentation on breast cancer awareness from our Dr. Rampaul. He apologizes for not being able to come as he had an emergency. And doctors are in demand. So he knows that we would have forgiven him, and we will certainly be able to hear from him another time. I just wanted to do a quick check to see if our regional Congress coordinator is here. Would you indicate, sir, if you're here?
Yes, ma'am, I'm here.
Wonderful. Thank you very much. Therefore, I am saying to us, please do not leave. We have some important updates for you, and it is about the CARAIFA Sales Congress. If you have that on your mind, here is our regional Congress coordinator himself, Mr. Denton Atkins, to share with you in 1 minute some exciting
Thank you, Madam PR Director. Greetings, Caribbean people. Denton Atkins here. First of all, I want to say thanks for all the checkups that has been done by our Caribbean family, based on the fact that we would have experienced a brutal storm, hurricane in recent times. Your support through phone calls, text messages, is greatly appreciated. As we try to get back to normalcy, we are still on track with our flagship CARAIFA event, which is our CARAIFA Congress. So I simply want you, Team Caribbean, to get ready to ignite your potential. If you have not registered as yet, please do so, because come May 2026, with that ultimate Caribbean motivational seminar, which is unmissable, I want you to be there. We are currently 85% sold out. Let me say it again. We are currently 85% sold out. So if you want to be party to that motivational seminar, now is the time for you to hit that registration and submit it so you can be counted. Look out for inspiring keynote speakers, practical workshops and seminars, unparalleled networking opportunities, fun-filled experiences showcasing Caribbean culture. The Trini flavor will be there because even though we are hosting in Panama, it is hosted by Trinidad, and certainly the food, the dance, and all the Trini culture will be on full display in Panama. And importantly, Team Caribbean, we want when you come for you to take away actionable strategies to boost your sales, and for managers and leaders, your leadership skills and business growth. Connect with like-minded professionals and build relationships. Don't miss this chance, Team Caribbean, to elevate your career and business. See you in Panama 2026, May 4th to 8th. Looking out to see you. That is it from me on this side.
Yes, thank you, sir. You're getting a lot of love and thumbs up and everything. We're all engaged and ready to go. And he got so excited, he went, what, how many minutes? But that's to tell you the level and passion that there is as we get ready for this powerful event. And you notice, please put on back your camera, sir. He's wearing pink. On the Jamaican side, we decided that we are repping in pink for the Day of Common Concern. And so if we are ensuring that it's understood that we are all in for breast cancer awareness. All right. We want to take just a couple of minutes to, I'm going to ask our Zoom master to let us kind of look to see who are the persons in the room sharing space with us. And if you can turn on your camera, feel free to do that and give us a wave. And I'll ask our Zoom master to do a little unmuting to allow you to just wave and shout out which country you're from. I want to know that you're on the platform and you're all in. You know, see the icons going up. Anybody? It's not going to be open for long. And okay, anybody from Trinidad?
Audra from Taifa, Trinidad.
Go, Audra. Yes. Anybody else from Trinidad? Barbados. Yeah. Barbados. Belize. I see Jamaica.
Belize here.
Yeah, from Belize.
From Barbados.
Belize here.
Wonderful. Wonderful. You're
Barbados.
all here. There you go. What is awake now? I see those pretty faces. Yes, the Caribbean warm. Thank you for standing with us from in Jamaica. Thank you so much.
Welcome, Dominica.
All right. Dominica. You saw Dominica?
Yes, we have Dominica on board.
All right. Beautiful. And we will definitely, I'm sure the questions will come and persons will be stating the countries they are from, so we'll get another good idea of all the persons who are repping. Thank you very much. All right, so we have another big one for you. And you're going to hear from another of our panelists. A consultant physician was trained at the University of the West Indies and in the United Kingdom. She's a member of the Royal College of Physicians in London and holds a master's in diabetes and endocrinology. This clinical director at the Maria Holder Diabetes Center for the Caribbean Disciplinary Clinic specializes in the education and clinical management of a wide range of persons at risk of and living with diabetes. This lady is actively involved with the Healthy Caribbean Coalition and the Barbados Childhood Obesity Prevention Coalition and works with the special needs population. Her lifelong goal is to see a reduction in the number of persons suffering from the harrowing consequences of uncontrolled diabetes. To share on diabetes awareness, we have someone who advocates for disability, a disability advocate, who believes Everyone deserves equitable and high-level care and the opportunity to live their best life possible, regardless of their disposition. Let us welcome and put our hands together and let's hear from our Dr. Diane Brathwaite.
Hello, good day to everybody out there. How are you?
We are
I should say
good.
happy World Diabetes Day. Just take the time to acknowledge that day. I seem to be having a little problem sharing my my slides. I would have just sent you let me see the presentation. Let me see, share screen. Let me see if this works. There's one
Yes,
thing about me.
we're seeing your slides.
Oh, are you seeing my slides?
Yes.
Diabetes, what you need to know?
That's correct.
Okay, wonderful. There's one thing about me. If somebody's going to have a challenge with technology, it's going to be me, regardless.
Did you want us to see
Okay.
your face? Because we're not seeing
No,
you
you're
on
not going to be able to
camera.
see my face. That is fine. Once you can see my slides, I'm happy with that. So this one is entitled Diabetes, What You Need to Know. Okay. So I'm just going to go through some basic ABCs of diabetes, but the topic is such a big topic. But do you ever think, what's diabetes? Or why is it on the rise? How do I know if I'm at risk? And how do I screen for diabetes? I only have pre-diabetes. Why do I need to be worried? How do I control my diabetes? My diabetes is controlled. Are there other things I should be concerned about? I'm so terrified I will get a diabetes complication. How can I prevent myself getting diabetes? Do I need to tell people I have diabetes? I find managing my diabetes as an older person very hard. What about my children or grandchildren? I am so stressed out, I cannot be bothered. If you've thought any of these things, you're like the majority of patients that I see who are at risk or are living with diabetes. And I think these questions are all important because there's a lot of there are a lot of myths and false things about diabetes floating out there. And as the host would have kindly said, I believe that self-education is empowerment. So let's just go through what is diabetes mellitus, and that is the correct word. So called it becomes raised due to what we call a relative that's produced by the pancreas. And you can see that in the little fleshy colored long organ there. It actually sits behind the stomach and underneath the liver, basically. And insulin deficiency occurs. Either you're not able to produce insulin or you're producing the insulin, but it does not do its job properly. And what is its job? Its job is to move glucose or sugar, which becomes available when we eat food, into muscle cells where it gets used for energy, or if our own body produces it. And one of the major organs that produces sugar in our body is our liver. It can break down stores of starches to produce sugar. I'll use the term sugar. So we always say that insulin is the key that lets the glucose into the cell. And I love this diagram, and I use it for teaching purposes a lot because you see how it's the key. It almost unlocks sugar channels in cells and allows it to go in. So you can imagine if you don't have insulin, there are no doors getting unlocked and there's no sugar moving from the blood into the muscle cell. Or think about insulin resistance. This is what happens in type 2 diabetes. You have a key, but the key just does not work. So therefore, you have this buildup in glucose or sugar in the bloodstream. So I always think it's important for people to recognize that if you have diabetes, you don't have any more sugar in your whole body than somebody who does not have diabetes. The problem is that the sugar or the glucose is in the wrong compartment. And that's where it does its damage. When the levels rise in the blood, that is where it can cause damage to any of the vessels in the body, any of the nerves in the body. And we have vessels and we have nerves from the top of our head to our little toe. So it means diabetes can be pretty devastating because it can damage almost any organ in your body. And that's why I call it a multi-systemic disease. We were talking about breast cancer. When people hear cancer, They get very terrified, very worried. I've heard in Barbados, some people say, well, I'm not going to screen because I don't want to know. But that's the same attitude sometimes we get with diabetes. But do you know that more people die from diabetes than die from breast cancer? All right. But yet there is a huge kind of denial and difficulty with acceptance of the diagnosis and managing it that we see in Barbados for sure. And I'm sure the wider Caribbean, because we know different across the Caribbean. We all the same Caribbean people. So we talked about diabetes.
Dr. Brathwaite, I think you're buffering on my end.
At the
Dr. Brathwaite, we are not hearing you well. The last thing that was clear
and
to
this
us
is a
when
big
you talk
concern
about
for
the Caribbean people. We're not hearing you well. Would you be able to go back a little for us, please? When you said we are all Caribbean people, that was the last thing we were able to hear.
Okay, so I was just saying we're all Caribbean people. Can you hear me now? If you can't hear me, please point it out, okay?
Yes.
Can you hear me?
We're
Yes.
hearing you now.
Okay, I will talk.
It seemed to be more connectivity than anything else.
Slower, okay? Okay, I'll talk. Okay, let me move to a different location.
The connectivity.
Okay, I'm going to move. Then you have type. Are me better now?
A little better.
Okay, have type 2 diabetes. Used to be more common in people, but can also occur. And type is rising fast as the age of me. Okay. Are you hearing me all right?
You're breaking up, in and out.
Oh, I'm so sorry. Tell me if you can. Hello, can you hear me?
Yes, we are hearing you when you ask that question. You want to say something else? Continue with this.
Okay, that's fine.
Please continue.
Okay. So what I'm just showing is the rate of diabetes in Barbados. And in 2015, we did a Health of Nations study which showed that 18.7 adults, 25 years and older, have type diabetes, and over the age of 65 years, it's about 46.5%. And what is fueling this rise in type diabetes? It is going to be obesity, physical inactivity, processed foods that we are using these days. Can you still hear me okay? Hello?
We heard you when you said
Hi.
hello and hi.
Oh my gosh, okay. So this is some of the risk factors for type 2 diabetes. We mentioned overweight and high physical inactivity, diet, older age, high cholesterol, sleep problems, high blood pressure, gestational diabetes. This is diabetes late in pregnancy, smoking, prediabetes, high intake, and of course, a family history of diabetes. Are we still connected?
Yes, we are.
My connectivities. Thank you. So what is prediabetes? Prediabetes is a condition in which the blood sugar levels are higher than normal, but enough to be classified as diabetes. But more than 84% of persons with prediabetes do not know they have it. But why is this important? Because prediabetes for developing type 2 diabetes, but also heart disease and stroke, and any of the complications of diabetes. So it is very to know if you do have prediabetes by having proper screening so that you can try to put measures in place to put it into remission or kind of get rid of it. So I always say, people all ask me the symptoms of diabetes, but the most common, absolutely nothing at all. And this is why screening is so important. When you have symptoms related to diabetes, normally the blood sugars are actually significantly elevated, and they have probably been elevated, which means they could have been silently causing damage. But some other symptoms are going to be things like going to the toilet after, frequent urination, maybe you're always hungry, having recurrent vaginal or yeast, sudden weight loss, sexual problems, numbness or tingling in the hands or feet, blurry vision, always thirsty, and always tired. So these symptoms should never be ignored, not in a child, adult. So this is a nice that kind of shows you diabetes is classified. Normally, it's at least that you do 2 tests. One can be a sugar, and the other one can be something called an HbA1c, which is almost an average sugar measure. And based on the table, you can then see if you fall into classification of being pre-diabetes or having diabetes. There's also another test called an oral glucose tolerance test, which is sometimes done to confirm if you have suspicion. We use it more frequently in children because it's a bit more accurate in children than the fasting and just the A1C. And that's how we can whether you have prediabetes or diabetes. So I just like to explain the term HbA1c, and it's something that I think everybody needs to remember, especially living with prediabetes or diabetes. This is a measure of how much sugar sticks onto your red blood cell. Now, the red blood cell for most people will live for about months. And so that's why some people refer to it as an average estimate of the blood sugar over a 3-month period. So if you have more sugar in your blood, your HbA1c will be higher. If you have less sugar circulating in the blood itself, your HbA1c will be lower. Everybody has a A1c reading because we all have sugar in our glucose in our blood. You're living with diabetes. Some people ask, how often should I be testing? Some people don't want to test at all. Some people test every morning only. Some will test sometimes very frequently. You need to decide with your healthcare provider the idea behind useful information from it. For myself personally, when I first start talking to someone with diabetes, I ask to check at different times of the day on different, not necessarily every day if they're taking tablets, but different times of the day. Do know now is that if you're living with diabetes, we want your sugar to be controlled, but we want them to be controlled times of the day. We don't want you to be controlled just in the morning, but then during the day, your blood sugar is shooting up in the air to 16, because it has been shown that when your blood sugar jumps up and down like that, you get more nerve damage and more damage to organs. So we want you to be controlled over the day. So what are some of the common diabetes treatments? And all of this is a nice and simple chart. I think it's put the wrong way around. I always say that the first treatment is your life, and that's going to be how you're eating and physical activity. And so therefore you then build upon that. If you need added treatments, maybe you may need tablets. Maybe for people, they may need insulin treatments. There are different types of tablets and there are different types of insulins. They work in different ways. They control different parts of the blood sugar cycle over a 24-hour period. So you have to be educated on the medication. But there is nothing that beats eating properly and physical activity. When you're doing that as your baseline and doing it well, you will always find it a little bit easier to control your diabetes. So we mentioned some of these things already. We're talking about diabetes, how to self-manage or manage yourself. You need to have nutrition education or understanding so you can manage your nutrition and your diet. Mention physical activity for adults should be a minimum of 150 minutes a week, but can go to 300 minutes a week. And you should be doing some training as well. Thinking about how you use medication, checking your blood sugars, preventing, detecting, and treating acute complications. So if you know that you're not feeling well and you're living with diabetes, you want to be checking blood sugars more frequently so that you can deal with anything that may happen. A lot of the times when you're sick, your blood sugar becomes high or any other acute change. My general principle is if you're living with diabetes and you notice some kind of acute change and you're not sure what it is, try to make contact with the healthcare provider to figure out what's going on with you. And then we have some chronic complications of diabetes. So you want to screen for them. You want to pick them up very, very early, because if you pick it up early, you are sometimes in the position to actually reverse the complication. But if you wait until you had it for six months, you may not be able to do anything with it at all. So once again, if you notice a change, get the appropriate advice. Goal setting and healthy. Oh no, you're a bunch of professionals and you know how hard it is to balance life. And when you're living with a chronic condition, you have to think about how you put first sometimes. In fact, we all should be thinking about how we put ourselves first sometimes. How are we going to manage our health? How are we going to manage things? How are we going to schedule physicality? Are we sleeping properly? A lot of things that you have to think about. So living stressfully, and what I would say is also a little bit randomly, because it's very hard to manage a chronic condition like diabetes when you don't have your game plan in order. And then once again, we're thinking about social living and mental health as well. Okay, we mentioned the balance. I'm going to go into nutrition in all detail because that's another topic all on its own. We mentioned physicality, of which there's so many benefits for outside of blood sugar lowering, direct blood sugar lowering. This is another area you can think about your drink. If you're drinking sugar-sweetened beverages, because when you drink a sugar-sweetened beverage, the blood sugar starts to rise very quickly. As soon as that beverage hits your mouth, the sugar starts to absorb through your gums. So a lot of the times the blood sugar rises so fast, even if you're taking tablets or insulin, it can't control it. And so this is another thing that we advise get rid of early. And I always say to patients, this is not customizable. You can't drink in sugary beverages day and think you're going to have diabetes controlled. Therefore, water or sugar-free beverages and generally we advise more water, infused water, vegetable juices, etc. Obviously, if you go to an event, you might have a little cheat in there and you may do it. But as I tell clients, well, if you check your blood sugar afterwards, you know it's be high, but know why, right? I say to them, okay, if you do it, but don't let me see you, you know? So think about what you're putting inside your body. Although we have a lot of processed foods that we're exposed to now, our portion sizes are one of the things that make it difficult for us to control conditions like diabetes. Our portion size is certainly here in Barbados big. Everything in Barbados, a lot of people put sugar in it. Even if it's a salad, it's going to have sugar in it. So you have to be very careful about how you eat out, and you may have to learn how to do more home preparations. I'm not going to go on any further. I would say we attended a very brilliant session this morning, and we spoke about the practicalities. So my challenge to you would be, how do you as an organization want to advocacy for diabetes in your territory, right? Or in your community? Because controlling conditions like this really is about what happens in the home or what happens in the community. And that's a whole other question as to how we empower communities to take charge of their health, their lives, and the health of their families. So the theme for World Diabetes Day is basically good self-management care across all life stages. Diabetes can affect you at any life stage, and we have to think about each life stage and how we deliver quality care. And as an organization full of business people, how do we promote corporate wellness? It's a very opportune to make a difference to people's health. So thank you very much for having me. I apologize for the problems. Hope you're able to get something from it.
Dr. Brathwaite, we are very grateful to you. And after everything, you got settled. So we were able to glean quite a bit from what you said. Thank you so much. And I could not help thinking of a quote that I read somewhere that says, just a spoonful of insulin makes the sugar go down. So what as you said, rethink your drink and managing our insulin level is going to be critical. You talked about the Caribbean people.
Right. I mean,
and in the olden days, I remember they would say, rather than saying I'm diabetic or I have diabetes, they say I have sugar.
We know that is.
Please repeat. All right. I'm sure we'll hear from Dr. Brathwaite again as soon as she is able to restore clearer connectivity. At this time, we want to have our two panelists spotlighted, and we're going to be moving into our question and answer session. Do remember that the topics explored today were breast cancer awareness and diabetes awareness. Today is International Diabetes Day, Awareness Day, and we are right on the button as it relates to our discussion and ensuring that all of us are educated some more and by extension empowered to conduct and engage in self-management. I could not help noticing that when it came on to the description of the lifestyle diseases and some of the symptoms that cross between both would be obesity and things like that. So again, lifestyle. The first question, I'd like to roll with the breast cancer one, using the privilege as a chair, and then to remind us that your question, your name, your question, and the country you're from, helping us to understand. Dr. Nimrod, are you still there? Can we see you?
Yes, ma'am.
And a lot is not said about breast cancer in men. Would you give a comment on that, please?
Okay, sure. So breast cancer, the incidence probably isn't going to be as high, obviously, as women, but we have at least 2% minimum men who present with breast cancer. As we said, men who have men boobs or male boobs, as we say, gynecomastia. So once you have that, as we described with the same diagram, lobules, ducts, etc., they can actually feel around when they do the breast exam, or women who might be, be around in proximity that they trust to actually do the same self-examination. And that's how men actually present. For them, first of all, the answer is no. right? Denial, I think, is always the first, and I think that's for everyone. Denial is normally the first aspect of having that reality grip, and it says, this is me? No, this can't be me. But again, with the correct navigator or support or this relative, say, listen, it's as you said, it's better safe than sorry. Let's go check it out. If it's nothing, it's nothing. If it's something, then guess what? We can do something about it, and that's the important part. When we get to just that initial, so that's really screening with symptoms, if you want to put it like that. But as we know in the Caribbean, sometimes it's a challenge for men to get to the physician because men don't want to hear bad news, right? So we get back to the mental health part of it. So if I can't think of it, I can't process it, then it doesn't exist, right? So, but the treatment is the same. We take out the lump, we test it, cancer or not cancer, and then we go from there. Yeah.
Thank you very much. Okay, so men, please remember you need to get tested too. All right. Our foundation chair, I saw that you were monitoring the questions. Could we have a question?
Sure. As the doctors and they were speaking, certain questions popped into my mind. And I decided let me take little notes as such before I forget in the mix of things. So Dr. Nimrod, while you are a breast cancer specialist, I know that as a physician, you would also know some of the parallel cancers, a bit of it, but you just more centered around breast cancer. The first question I want to pose to you is, there are so many different types of cancers based on the different parts of the body. If you had to share with lay people like ourselves, which ones tend to be more genetically hereditary as compared to which ones tend to be more lifestyle cancers? How would you explain that to this audience?
Okay, so I will broaden it out a little bit. So breast is one of the specialties that I do. So my fellowship is in cancer prevention and control. So I do all cancers, and hematology, it's just like the lymphomas. So if you want to ask anything, I can answer all the rest as well. That's fine. So in terms of the cancers that show up in terms of frequency, so we know it's breast cancer, it's going to be prostate cancer, colon cancer, ovarian, well, not ovarian, endometrial cancer, sorry. Lung, yes, but lung is not just smoking alone, right? So you actually have another type of cancer, as we say, that's not squamous, that's not affiliated with smoking. So we have a few. So normally the guidelines we wrote would be for the top 7 that we have in the Caribbean in terms of 6 solid tumors, colon, rectal, right, and multiple myeloma, which is a hematology one. But getting back to what you're saying in terms of genetic or hereditary, I think back in the day, that would have been the primary presentation. You know, you knew someone had breast cancer in your family, and then you're almost certain that it will pop up according to, as we say, the pedigree. We do a line, grandparents, children, grandchildren, and it will show up in there depending on that particular gene or locus when we do our genetic testing. So across the Caribbean, different countries do have the capacity. If it's not in your country, for example, I was in Dominica, if it's not in country, then they send it out, which is what most islands would do if we don't have that assay available to see if there's that genetic component. But for the top ones that would have it, it would be breast cancer, prostate cancer, colon cancer, which comes in the series called Lynch, right? Lynch syndrome. So they're different, again, cancers that present along the continuum. So you might notice dad had prostate, aunt had breast, cousin had colon, and you're like, is there a connection there? Yes, there's a connection there. If you actually pick up the persons and what types of cancers they're presenting with. Ovarian also goes with breast as well. So, you know, I had a patient passed away the other day. She presented with endometrial cancer, cancer of the womb. She wasn't 45 yet. And then 2 years down the road, she got breast cancer, and it eventually progressed to stage 4. And she's one of quite a few patients we're seeing developing with 2 primaries, as we call it, and not metastasis. So
where it spreads from the primary organ, like breast to another place. Like breast likes to go to bone, lungs, brain, liver, right? Breast can go to quite a few places. But we also, as we said, try to make those connections. So in terms of those that are spontaneous mutations, right, which quite a few happening now, and even the genetics on those cancers, we're looking like younger women. I'm going to say triple negative disease, and let me clarify that one time. When we take a lump from a patient, we take out a breast lump, we will test it to see, first of all, from the pathology side of it, what type of cancer is it? Because we need to know which treatments are going to work on the particular type. The second one we're going to look at is to see how fast or how slow growing the cancer is, right? So those actually get grades as well. We want to see when we actually get to the surgery, how far has it spread, extent of spread, right, under the armpits or the lymph nodes. And then when we do a CT scan, we want to stage the disease. Are you stage 1, 2, 3, 4? We have 4 stages, right? The tissue itself is also sent off for testing. So we want to know what are the receptors, right? So there are 3 main receptors we look for: estrogen receptors, progesterone receptors, and HER2. Those are the most basic ones. I mean, we have others from the genetic panels, but those are the 3 ones that will decide from our current treatments which other treatments you get. So getting back to your question with respect to lifestyle diseases would be, again, smoking as a risk factor. I dare say, and I tell my patients, watch to see how much estrogen containing food you get. So we love KFC in Trinidad and Tobago, right? Chickens actually get blown up, as we say. We try to increase or speed up the rate at which they mature. When you are consuming, as I normally put it, it's quantity, right, frequency, and duration. Those are my 3 topics when I talk to my patients. What is the quantity that you're going to be eating, whether it's fried food or whatever else? And then what is the frequency? Are you eating it every single day? And then what is your duration? Is it going to be 6 months? You're going to be having KFC doubles, whatever. So you understand how you keep increasing the risk going forward. And that's what you call a modifiable risk factor. That is something that you can actually change when you make a choice, right? So that doesn't have anything to do with the genetic components per se, but with the modifiable risk factors. If I stop smoking, I stop the alcohol binges, I start to exercise, then those things help in terms of doing a risk reduction. So the caveat is, it doesn't say that you won't get cancer, right? So that's the other important thing. I've had patients say, oh, I'm a gym instructor, I'm fit, I go every day, and I still got pancreatic cancer. What happened there? So that's, again, a spontaneous mutation, right? If you've done everything that you can, that takes your risk down. So we got him at a stage 1. That's fine. Good. If he wasn't paying attention to his diet, his lifestyle routine, etc., I'm sure he would have presented much later at a later stage of disease. Okay, so that would kind of be the difference between genetic hereditary, which can also be impacted by lifestyle changes, and then those are just random or spontaneous mutations based on a few things. So I will also stick climate change and cancer in there, which is another topic that I like to speak about, but I'll leave that for another day.
Thank you for your answer. The reason why I asked that is of late, the common feedback that I've heard of is that most cancers are more lifestyle cancers rather than genetic cancers. In my own family line, my dad would tell me, oh, your mother's side, right? Because my elder sister passed away 26 years ago at the age of 42 from pancreatic cancer. And whatever the textbook said, that is how she presented, which was, by the time you find out, it's at stage 4, and it would have already spread to the bile ducts and the surrounding area, and you don't stand much of a chance. I have a cousin in China who was diagnosed with pancreatic cancer too. He didn't live as long. And I have an uncle who never smoked on my mother's side as well. And he died from lung cancer. But as you said, you don't necessarily have to be a smoker. It could also be the environment that you're in that you can contract. But as my dad would say to me, or is your mother's side of the family, you know, because all three were related directly to my mom rather than his side, you know. And so in Trinidad and Tobago, as you would know, chicken is one of the main staples for protein, right? And we know exactly, as you say, that chickens are fed a lot of hormone to grow faster, to be able to send them out faster and stuff like that. And one doctor made a joke, and I don't know how true it is. It said that's why men are growing more breasts in Trinidad because of the amount of chicken they consume. I don't know to what extent that is true as compared to even up the islands, as the case may be. But in relation to testing for cancers, I guess that each type of cancer would carry its own primary tests to find out. But it comes right back down now to what can I do to be proactive rather than reactive, especially with regard to testing. I know for breast cancer, as an example, it starts at the very basic that we hear right or wrong, which is self-examination, right? And there's so much videos and information that is put outside there with regard to how women could, at least when they're taking a shower, check themselves, and only when they pick up something, you know, peculiar, because it wasn't there before and all of a sudden it's there now. And it doesn't have to be cancer, as you would see. It could be anything. It could be fatty tissue. It could be anything else, right? But there are so many other types of cancers, as you see. And so what are the other tests? Are there blood markers that people can check for? And then why would somebody just go out there and have to check for these things? I know for men over a certain age, it's important to do PSA, or at least what we call the finger test first, if you don't want to, but a lot of guys don't like the finger test, so they just go and do the PSA. And then what would be considered normal with regard to that PSA number range? Yeah, so it's a lot of information. So I listen to you.
Thank you so much. So incidentally, Larry Tag chose his name. He's from Trinidad and Tobago. Okay. All right. Do we have any other questions? Any questions for Dr. Brathwaite? Diabetes. And are we seeing any questions related to that in the chat? Or anybody would
There
like
are
to
questions
raise
in the
his or
chat
her hand?
that popped up when I was taking my little notes as I listened to it. Again, like cancers, to what extent is, for example, diabetes hereditary, Dr. Brathwaite, as compared to lifestyle? Is it 50-50? Is it more lifestyle than hereditary? I wait for your answer. Dr. Brathwaite? Don't forget
So
you're
Boyer,
muted.
me?
Yes, I was
Hello?
asking. Yes,
Oh,
we are hearing you. And I was
can
asking with regard to diabetes and
you
hereditary as compared to
hear
lifestyle.
me? Yeah.
Go ahead.
Diabetes type 1, both type 1, hereditary components. Three components are much strong. We always say that life is similar to the egg of the cancer was actually, and they picked up earlier. Somebody, it may not progress as makes sense. Lifestyle kinds or in other things that are going on can underline and
Dr. Brathwaite.
So that's what we're saying. Family.
My apologies, Dr. Brathwaite, but for some reason you're buffering again, even though your video is off. So we're not being able to pick up the entire conversation. It's very fragmented.
Dear.
You want to change location if you're on your phone, maybe
Okay.
a better location around the house. While you do that,
yeah,
you could speak while you're doing it, and so we could
Can
hear
you now? Oh,
keep talking. We'll hear.
can you hear now?
Yes, I heard you say, can we hear now?
Okay, so diabetes is hereditary. Yeah, so diabetes is but triggers is on from
Dr. Brathwaite, my apology again, but you breaking up and we're not hearing you at all now. So while you try to maybe sort out or change device if possible, I will pose another question to Dr. Nimrod, possibly while maybe you change your location or possibly device. Dr. Nimrod, I'm happy to hear that while your specialty might be breast cancer, that you do a lot of the other cancers, and you mentioned hematology, which deals with blood.
And global health is my specialty in public health. So I do infectious disease, I do climate change, I do occupational, so I do a few.
I don't know where you were able to store all of that in this brain of yours with regard, and you look as though you just left school the other day, you know. So I was asking you before we went to Dr. Brathwaite with regard to the issue she was having, with regard to the testings of the other types of cancers, especially utilizing blood testing rather than other forms of testing.
Okay, so I can, no problem, that's fine. So normally we will reference what we call the American Task Force on Screening. So they would have established a set of guidelines in terms of what we utilize to screen when persons reach a particular age. So we have two arms, if you want to put it like that. So one, if a patient comes in with symptoms, so let's say for prostate cancer, men normally say, I have difficulty, passing water or urinating or forcing to start a stream, or that doesn't automatically mean prostate cancer. That could be a swollen prostate from benign prostatic hypertrophy. It could be prostatitis. You have a urinary tract infection because you're not drinking enough water. So we tell men not to get like all excited that it's something terminal. Come and discuss what your symptoms are, and then based on your age and whatever clinical presentation you have when you come, we sit down and we work it out, and then we would know exactly what to request in terms of investigations, right? So that's one broader set in terms of symptomology coming in. The second one in terms of cancer specifically and the testing would include from the age, as we said, different ages pretty much respond to the presentation globally from the cancer registry. So now we use age 40 for breast cancer. Before, cancer was a word that was over 50. That's not going to happen before 50. But based on the statistics that we're getting, it goes a little earlier. So for women, we would say, yes, the mammography or the mammogram is the gold standard for breast cancer. If it's a younger woman and they have dense or perky breasts, then we would do an ultrasound, because to put that between, two plates, the concept is to increase the surface area and, kind of spread it out. So we could check to see if there's any calcifications, anything that looks irregular is the purpose of the mammogram. And it's still, as we say, the gold standard. However, there are other modalities that we can use. If a patient has, for example, we say multifocal disease, so it may not just be in one breast, like lobular. Sometimes you find a breast lump in the right, but when we do the assessment, we find lumps in the left. We may send them to do a breast MRI as well. Okay, so we can do that as well. And then we get to the concept of staging, where we do a CT scan. So we want to see, again, is it only in the chest, may spread in the abdomen or the pelvis. So we would use that as a modality. We move on to actually looking at the blood testing. So we don't, and I caution, we don't use tumor markers as diagnostic, with the exception of the PSA for men, right? So men, we would look at 0 to 4. We try to ask you to remember your numbers. So 0 to 4 would be normal for men, right? Nanograms per milliliter. However, with women, there's something called a CA 15-5 blood test, or maybe a CEA. We don't use that to diagnose cancer. Same way with a CA, 125 ovarian cancer, because it's elevated, she may be going through her ovulation and the cycle, and it's going to go up. And we will repeat that, right? So I'm always cautious to tell people that we're going to repeat that in a couple of weeks, etc., to compare, right? So we don't treat the numbers, we treat the patient when you come in. So there's a blood testing, then there's genetic testing where we can take a sample from the mouth, buccal swab. We can actually take blood samples now and send that off to test for genetic testing or tissue. So it really depends. And this month is also pancreatic cancer awareness, by the way. So my great uncle had pancreatic cancer. He was Asian as well, right? So my family's Chow Tai. And when you said that, I was like, I have to check that link now. No, but pancreatic cancer, just as a nugget, depends on where it's located, right? So I see Doc is saying that diabetes is hereditary, right? And then we also have, but lifestyle triggers it strongly, right? Good. So that is true as well. So lifestyle can change how it aggressively presents, right? So I think I heard when she was saying type 1 diabetes, we normally know will be the hereditary one. In NCD, on the other side, we would normally say that, as you said, the lifestyle factors can obviously decide how aggressively, when it presents, etc. But it's always a silent disease unless you look for it, as you said, with the HbA1c test, which is the same sugar molecule on the red blood cell, which lasts about 120 days, which is why we repeat that blood test every 3 months. So you don't go doing an HbA1c every month. It's not going to tell you very much. It's going to be an average of the daily values of your blood sugar during that point in time using the red blood cell and that little marker.
Dr. Brathwaite said the inheritance or genetic inheritance of type 2 diabetes is stronger if there's a sudden onset of diabetes, especially if there's poor, let's see. Oh, it came out. For some reason, I'm not seeing the messages that disappeared.
Can the person who posted that question, let us hear you, please? Is it possible?
Dr. Brathwaite, you want to say something? Let's see if your audio got better.
No, I'm saying, can you hear?
Yes, continue speaking and we'll see.
Can you hear me now?
Yes.
Go ahead.
Oh, I apologize. I believe this has happened. I was just agreeing sudden onset of diabetes, especially or required from the onset adult as other suitable and invest pancreatic. I've had those cases seen in the last.
Dr. Brathwaite, you kind of broke up there, but I want to see if Dr. Nimrod could translate that, because she, as a doctor, she may have picked up certain words that you were saying there and maybe expand on them.
Oh, no, I was just going to ask her if she could move like outside, maybe in the room where she's at. The location in the building is probably precluding her signal a little bit. So if she can like step outdoors.
I'm going.
Yeah, if you can step outdoors in the corridor somewhere else where there's probably less
Okay, any luck?
Yes, keep going.
Any luck? Can you hear me now?
Yeah, go ahead, speak, and
Keep
we'll
going.
see if it's continuous.
Oh my word.
That's better. Keep going.
Oh, okay. I'm just saying that sudden onset that's very controlled or require insight onsets, and you have other, we think a lot of this. But there's also pancreatic alcohol abuse. And the comments that this is a in a poorly controlled few years compared to 15 years in the last 2 years. That is in.
Okay, Dr. Brathwaite, you're still fragmented for some reason, but I'm able to see your message on the chat, which
Okay,
which spoke that if both parents, go ahead.
I also want also cancer, poor control, diabetes.
Okay, you're still fragmented, Dr. Brathwaite, but I am seeing your message on the chat, and it spoke to if both parents are type 2 diabetic, then of course the risk for becoming diabetic at an earlier age is very high. And if there is a sudden onset of diabetes, especially if it's very poorly controlled or requires insulin from the onset, or the person has added symptoms, we do think about and investigate for pancreatic causes, including pancreatic cancer. And so in hearing the word pancreas and pancreatic cancers and thing, I'm assuming, not being a doctor, that that the pancreas controls a lot of the counterbalances and with regard to insulin and the onset of diabetes, not necessarily reaching the stage of pancreatic cancer to trigger it, but if you're having problem with the pancreas. So Dr. Nimrod, there are tests, I believe, that that people can do when they're doing, for example, a full blood profile. You want to share a bit on that, on tests that could possibly, when a person does a full medical with a full blood profile, if there's anything inside there. Go ahead.
Right. Okay, so we normally don't screen from a cancer perspective, pancreatic cancer. So we don't screen for pancreatic, we don't screen for ovarian. The main ones will be breast, colon, right? Because we have those established as guidelines for screening. Because the cost risk to benefit ratio, again, doesn't necessarily result in a positive case. So we would ask from the blood profile, for example, and we at HbA1c, sometimes we would do a fasting. Ideally, for pancreatic, we could do a CA19-9, which again is not supposed to be a screening tool, because if somebody had a binge of alcohol the night before, your CA19-9 can go up, right? Because the balance is between the beta cells and the alpha, right? So we have the insulin balancing out in terms of taking up sugar, and then we have the reverse in terms of, releasing. So we don't normally use it, but if it's in your panel and you see it elevated, that discussion will be with your healthcare provider to see, what is happening, along with a history and a physical examination, if that puts you at risk for developing same, as you said before, right?
So you mentioned your primary healthcare provider, so that would be the doctor that you normally see.
Correct.
And then he would refer if he thinks that it's important now to refer you.
So they're supposed to be the gatekeepers, or you can go through your tertiary center. So I will add at this juncture that one of the reasons that CAHU actually advocates for access, #access, is because sometimes, not just in Trinidad and Tobago, maybe even the Caribbean, there will always be healthcare gaps globally. And the challenges in terms of finding a symptom to actually having something done about it, that interval can sometimes be protracted, so it may take sometimes 2 months, 3 months, 4 months, sometimes something as simple as a pap smear may take you 6 months to get a report, you know what I mean? However, insurance now gives you that additional advantage, from two perspectives. If you do it from, a health and wellness and preventative aspect, as I tell patients, it's almost as if you're rewarding yourself, so you go, you get percentage back, and great, you can breathe and rest assured for the time being that I checked up on myself, even though nothing's happening. So that's one thing for insurance. The second part of it is that if persons actually have the insurance and they have a cancer diagnosis, because again of challenges within any healthcare system, they can decide how they're going to balance the use of it, right? So they may be able to get some of the basic tests, but then if we want anything advanced, for example, they're not necessarily MRI machines in public, they can pay to have that facility afforded to them. Or if there's a particular drug, because sometimes our drugs can be expensive, right? Especially like immunotherapy. Sometimes it can cost as much as maybe 30,000 TT up. Then, you have that as an additional backup. If I don't get it in public, then I can, still have access to claim and to purchase it in private. So ideally, you want to have a smoother transition in the treatment period from diagnostic to treatment period, so that patients don't have any unnecessary breaks with respect to their treatment. And then obviously to lead to better, as we say, outcome and survivorship is what we look for.
I saw what Dr. Brathwaite posted there, which I didn't know, that diabetes also raises or will raise the risk for cancer diagnosis on an individual, right? And I didn't know about that one. So thank you for that one, Dr. Brathwaite. Dr. Nimrod, when we talk about cancer screening, most people don't go to investigate cancer unless, unlike the PSA, when you cross a certain age, you could do an actual PSA blood test. But the other tests are not really something you could necessarily go and get done. So is it like chasing it down, that you have to wait till something manifests to be able to do when we talk about cancer, at least at this stage globally?
Excuse me, Larry, there's a question from Juanita.
I was going to say that. Yeah, sorry. Go ahead. I thought you didn't see it, Shirley. Go ahead.
From Antigua, yeah.
Juanita from Antigua and Barbuda.
Yes.
Could you please comment on the value benefit of genetic testing for someone with family of breast cancer who is now being treated for breast cancer? Could you comment on the value to benefit of genetic testing for someone with family of breast cancer who is now being treated for breast cancer?
Sure, that's not a problem, and we pretty much do that all the time. So what we're doing is a risk evaluation for the other relatives within the family. We do it for two reasons. If there is a family history, we want to see, for example, we're looking at BRCA testing. So this young lady would have made BRCA popular, Angelina Jolie, if you remember, right? Showing up BRCA positive, and she chose to have an elective double mastectomy, right? To remove the breast. If a patient shows up, so depending on if it's a new case, if it is that the patient is a young patient, or a strong family history, then yes, there is a benefit, because we now want to know, when do we start screening, and what are we looking for that very close network of relatives, right, going forward. So if it is that we find out the same genetic discussion that we have in terms of family history, that there is a gene there, then we bring the family in and we say, listen, we've screened one, we found this particular gene positive or these two genes positive. We'd like to know who else again in your family may be carrying this particular genetic mutation, and then we want to screen. We don't want them to present with the disease, right? So that's one of the main things that we would do in terms of trying to have that evaluation done so that we can protect the other family members, so that if it comes on, we technically already have eyes on those persons who would have maybe a 50% risk already.
Okay, Dr. Brathwaite said that she wants to highlight that people with diabetes need to screen regularly for the complications of diabetes, that they should be screening regularly. And she went on to say an area of concern is in non-insurance of persons already with diabetes as a pre-existing diagnosis and more coverage for lifestyle modification measures. And I hear you. And if I had to wager a reply on behalf of insurance companies, again, when they talk about pre-existing conditions and our various population sizes, how does one now quantify to put a cost in to now taking on people with pre-existing conditions and to be able to cost it in a manner that people could still afford to be able to pay for healthcare. And I think that is one of the biggest handicaps that we have in the Caribbean individual countries and stuff as compared to our population size in the US of 300 plus million people. And a greater percentage of that. So the whole principle of spreading a risk. But when we treat with insurance companies that operate in the region and the population size, how do they possibly cost to include pre-existing conditions, not only with regard to diabetes, but with regard to other diseases? But that is the challenge that we have in really being able, when we go out there to speak with clients, to help them to understand, especially when we could get statistics from the medical fraternity of that prevention is better than cure, that not only from the perspective of well-being, but also from the perspective of I tell people, I said, nobody buys insurance with the intention of hoping they have to use it. But you can't do it after the fact, because that's when because of your urgency, all of a sudden it becomes you want to be able to pay for it, but you're already at risk. And if people have to wait till they're already at risk, then nobody will be able to afford insurance. And that is the dog chasing the tail kind of situation there. But I know you had from our private discussions, you were talking about the cost of medical care, that medical care is available, but it comes at a high cost that public healthcare systems are not always able to carry it. You want to share a little more extensively on that? Especially for our listeners who are all insurance practitioners, most of them, and the urgency to have them put to their clientele the need for putting things in place insurance-wise to be able to fund care when it is available. Yeah.
Right. So in this particular platform, to make it really simple, as you said, no one takes out insurance hoping that you would be sick. But in the day and age that we're living in, that's normally my argument, where everything is unpredictable. Today, inflation is sending up the cost of a lot of things. So if you can actually have that coverage at a lower rate, why wait to pay $150 a month when you can get it cheaper, or the later you start, obviously, the premiums are going to be more expensive. And by then, if you have a non-communicable disease. As we said, anyone, including even lung disease, is another one. We don't want you now trying to see if you qualified, if you missed the qualification, because there's some exceptions with some plans, just get it done. Even if it's a smaller limit, it's still better than having no coverage at all, actually. And I think persons appreciate that because the public systems are totally filled to capacity, not just here, that's globally, right? And again, as Doc would have said, it's the lifestyle choices that we're making. Some of it modifiable, some we can't. Like when I speak about climate change, there are other things that we don't directly have a control or say over with respect to the environment. But again, if it happens, to manifest, whether it's skin cancer, lung cancer, whatever, you need to have the opportunity to say that I have something in safekeeping that is going to protect not just you, it's going to be your family, it's going to be, your job security. So when I spoke to the fact that cancer is multidisciplinary, there's so many other persons, not just the physicians alone who are actually involved in the treatment. We have to get mental health advisors or counselors for patients. Sometimes we don't have it in public, we don't. So they may pay to go see and speak to someone, about anxiety, depression. We have social workers who deal with, loss of income or earnings when you have to start your treatment or even under surgery, because sometimes we have to give you at least, a month, 2 months, 3 months to recuperate. You're not going to be making, your total after you finish with your workman's compensation, etc., or NIS contributions, So again, not being prepared to fill those gaps or those rainy days, whether it be cancer or any other disease, it is better to have, some sort of security measure in place. And that's, I think you need to make it relatable. And if you can find persons in their network, family or otherwise, because storytelling is a very big part of how people connect to things, then that makes it, even easier for them to internalize what you're trying to present.
Thank you
Thank you so
very
much,
much,
Dr. Nimrod.
Yeah.
You sound like a sales representative.
They've been teaching me well now.
Yeah, absolutely. So we're going to be talking off the air.
Before I hand back
absolutely.
over to you, Ms. Daly, Juanita said.
Thank you so much. Yes, it
Juanita
says,
said something.
okay, sorry,
Juanita,
you're saying?
Yeah, Juanita said that then how does it help the person who has already been diagnosed? And because genetic testing as just one test that she says is very costly. And
yes.
And I
can answer that.
Yeah, I can well imagine, but I tell agents throughout the region that, and this is why it's so important. We have, number one, we have to try and reach the public that to put things in place before and not after the fact, because it's just not possible to put things in place after the fact. And we
Thank you, sir.
we may meet someone who is already diagnosed, but then they have siblings and they have families that are not diagnosed, and we have to try and reach them, because if we don't do anything and their risk factor has now increased because of somebody in the family being diagnosed, if we don't tell these stories to help them now put things in place because they are not diagnosed yet. So we have our job to do as best as we can, and that's the most we can do. It's almost impossible, because many years ago I heard an actuary say that if insurance companies wait to now offer protection to people who are already diagnosed, then nobody will be able to afford insurance. The cost factor will just be too high, because they wouldn't be able to maintain a premium that is manageable. And that is why one of the main principles behind insurance is trying as best as possible to protect the unknown risk and not the risk that is already there. But when the risk is there, with regard to up to a point, then a person can get coverage possibly still, but with a medical rating, right? But it's almost impossible to wait till people are already diagnosed to be able to now offer them that protection, because then if that was the case, everybody will just wait till something happens and insurance wouldn't exist because it just wouldn't be able to sustain itself. Yeah. Dr. Brathwaite
Okay,
said
sir.
behavioral change and mental health support, and we have to change the behaviors. Yeah. And I agree with you totally, Dr. Brathwaite, because there's so many things that involved in medical care. We're talking about the illnesses directly, but then we have all the family counseling aspects and all these things that I'm sure almost everybody in the Caribbean here may have a friend or a family who is diagnosed or has been diagnosed or at risk for major illnesses, and I don't think it's getting better. I think lifestyle is things are getting worse. People are just living a very hectic lifestyle, and we don't realize that all of that increases the risk for everything else. Yeah. The topic is going very well. It is almost 6, and so we see here that I want to extend an invitation from the foundation that we will try and see how we could do similar programs, not just once a year, but possibly other times of the year, because I firmly believe that one of the things we have to do that is within our power to do is raise awareness. And I know from a medical perspective, prevention is always better than cure. So I'll pass you all back on to Ms. Daly as she takes us. We promised that we'll finish by 6. It's almost 6 now. So I hand back over to Ms. Daly.
Thank you, Foundation Chair Taiju. We have had a proper diet, and we have been challenged to change our lifestyle, rethink our drink. We had comments like that. And of course, everybody has sugar. It's just that when you're diagnosed with diabetes, it is found in the wrong compartment. And from our 2 presenters, we were motivated and inspired, as well as challenged for some of us to ensure that we engage in corporate wellness. We want to say thanks to both our presenters. We want to say thanks to them for enlightening us and whetting our appetite again, as well as sensitizing us, making us more aware. And I know that we have diverse age group on the platform, but all of us have a role to play, particularly as insurance sales agent, in ensuring that we are breast cancer aware, diabetes aware, chronic illnesses aware, and begin to be the leader in lifestyle changes. So thanks again, and we'll certainly be in touch with our doctors, our expert panelists, Drs. Nimrod and Dr. Brathwaite. Ladies and gentlemen, our time has come to an end, and there's a lot for us to mull over. I want to thank you again for being here and for choosing to stay with us. This session is now adjourned, and we want to wish you a pleasant weekend, a restful one. And remember, whatever you're going to drink this weekend, be careful. Think about what you heard. And I cannot forget that chart, which has all the food groups from which we should really be making up our diet. So let it begin with us. The Lord bless you, and do have a wonderful weekend.
Thank you, everyone. Have a blessed weekend. I will be drinking water.
That's right. Drink some more water.
Water for you. Water for you. Thank you, Dr. Nimrod.
Thank you, Lucia.
And Dr.
Thanks,
Brathwaite.
everyone.
Bye-bye.
All right. Take care,
Bye.
guys. Bye-bye.